7 millimeter incision. Dear colleagues, this is a small incision cataract surgery for PGTs of developing countries. Let us see what happens. This is how I incise the conjunctiva very close to the posterior aspect of the limbus. Now in this case the tenons is very thin, so I am taking the tenons along with the conjunctiva. When the tenons is very thick, I dissect in 2 layers. That's it. This is a 7 millimeter, little larger, 7.5 millimeter incision of conjunctiva. Now very mild bipolar wet field cautery is done. Just touch on the blood vessels and come out. Take care that you don't char the sclera. The sclera should not be charred at all by your cautery. Now this is the incision. This you have to learn yourself, how much force you will apply, the feel of the tissue, how much depth you will go, that will come with your experience. And now take a crescent blade and go to equal depth all around. Feel that you are at equal depth. This is a straight tunnel and it is at adequate distance from the limbus, and we are going to get a self-sealing wound in this case. Now be at a same level, be at the same level all around. The anterior lip of the wall, the anterior wall of the wound of the tunnel should be of equal width all around. Go a little bit into the clear cornea as I have gone in this case, and the inner opening is a little larger than the outer opening. Now make 2 side ports. This is one on the right side. You can manage with 1 side port, but if you have plans to learn phacosurgery, make 2 side ports. Okay, 2 side ports are made. Now inject air into the anterior chamber. This is air bubble, and now inject Trypan blue dye, 0.6% Trypan blue dye in the antechamber and stain the anterior capsule of the cataractus lens. Now wash out the dye. You don't have to stay for 15-20 seconds. Just if you stay for 5-6 seconds, that is enough. Enough staining occurs in that time. And now viscoelastic substance is injected. This is HPMC. This is very economical. This surgery is, you must learn if you are in India, Bangladesh or Nepal. You must learn this surgery, and many other countries, many other developing countries. There is a huge backlog of cataract, and unless you learn this surgery, you will not be able to cope up. You will not be able to give good vision to many people. Now how to do capsulorhexis? Incise the capsule. Now flip the capsule, means its posterior surface will face the corneal endothelium. Now we just rotate this flap. I go anti-clockwise. I don't know whether you will feel comfortable clockwise or not. I go anti-clockwise and make this capsulorhexis. Try to be at equal distance all around from the dilated pupillary margin. And in Thus you can get a round rhexis. That's it. Now is the time to enter into the eye. When you cut, when you go anteriorly and sideways, don't cut the tissue when you are coming back. Cut when you are going anteriorly and sideways. The anterior lip or the funnel that is on the cornea is a little larger than the end which is on the sclera. Now hydrodissection is being done. While hydrodissection was being done, the portion of the anterior capsule that is torn, it came out. The nucleus is depressed gently and it is rotated. You can see that the nucleus is rotating, but in this case, though the rhexis is quite large, the nucleus didn't prolapse into the anterior chamber. What does it mean? It means the nucleus is big enough. It's too big to come out through the opening in the anterior capsule. Now I'm taking two instruments. You can manage with one, but I'm trying to be bimanual nowadays, trying to use my left hand as much as possible. Even I'm trying to do phacosurgery with my left hand, though it is my non-dominant hand. Yes, I have prolapsed the nucleus out of the capsular bag and the nucleus is now in the supracapsular area. Now, I usually use a fish hook to deliver the nucleus. You have to find out which instrument is comfortable for you. This is how you use a fish hook. Go, turn it so that it engages into the nucleus and come out like this. Go flat, turn it 90 degree and come out. Now here it is. I'm going behind the nucleus, I've turned it and I am pulling it. Now what happens, this nucleus is too big for this 7 mm incision. So what has happened is I have not been able to deliver the nucleus, though it has engaged nicely into the wound. So what I do is I take a chopper, phaco chopper, not Sinski hook, chopper, this is a little tougher, in my right hand and push this nucleus from behind gently, and gradually it comes up to this. Now I come out and engage it here and rotate the nucleus. Here it is. The nucleus comes out. That's it. So a big nucleus has come out through a 7 mm incision. Now I irrigate the anterior chamber, remove the epinucleus. Now if you remove the cortical matter through the side port, the chamber remains better formed. Both the anterior capsule, both the posterior capsule and the corneal endothelium are at safe distance from the instrument you are working with. This is a Simcoe cannula. I work with a 23 gauge Simcoe cannula. That's it. Most of the cortical matter has been removed. Now I'm going through the left side port to remove the cortical matter which is there at 11 o'clock. That's it. The cortical matter which is there on the right side of the wound has been nicely removed. Now viscoelastic substance is injected into the anterior chamber. Here is the viscoelastic substance. This is HPMC, hydroxypropyl methyl cellulose. Fill up the bag, fill up the anterior chamber. Now this is a PMML lens. This is the best lens in the industry. It remains clear throughout life. It has got square is 6 mm optic PMML lens. It has got 2 dialing holes. This lens never loses its clarity throughout the life of the patient. The only disadvantage is it cannot be folded and it is very economical. Yes, if it is very economical, you cannot do business with it, and that's a problem for the business people. But this is a very good lens, probably the best lens available in the industry. Now I am irrigating out the viscoelastic substance. I've gone behind the IOL and removing the viscoelastic substance. This bimanual IA is just to show you that if you have 2 side ports, you can learn bimanual IA even through this surgery, manual small incision cataract surgery. Now you hydrate the side ports and we are almost through. Going to complete this case. Now increase the magnification and examine the anterior chamber very minutely. Have you left any cotton fiber? Is there any lens matter anywhere? Is there any cortical matter anywhere? Examine it very nicely, and when you are satisfied that nothing is left, you have done a thorough job, form the anterior chamber like this. Suddenly come out. And now examine the wounds, examine the intraocular pressure. See, there is no leakage, the wound is nicely sealed. This is moxifloxacin over the wound. And now to reposit the conjunctiva, just inject dexamethasone, gentamicin near the insertion of the suprarectus tendon. The conjunctiva advances towards the limbus. That's it. Thank you very much.